Well, we're going to go ahead and begin, and I'm sorry that we had to start this early. I actually have to travel today, but I do want to get into our next week of therapy with our patient in our minds, and as we're going and directed. So we only have 4 of us online right now, so feel free to unmute yourself, ask questions, interject things that you'd like to say that have been successful for you. This is time that we can all learn together. But again, this is the Emergent webinar series. We're going through the first 8 weeks of therapy. Basically, these 8 weeks are dealing with just a basic skills case, not really delving into somebody that has a very complicated strabismus or amblyopia, but what we would do for just a basic skills case. That being said, as developmental behavioral optometrists and us as vision therapists, really everything that we do would be in that developmental pathway, would work for no matter what the diagnosis, because we're doing the things that are going to be necessary for the best binocularity of the patient. And so therefore, it is going to meet the needs of just about any patient that we have. We just have some modifications if we are working with a specific diagnosis that we'd have to contend with. So introductions, my name's James, I'm a COVT, and I'll be the trainer and discussion leader, but I hope that I'm more of a discussion leader than just doing some training, because I hope we can all work together on it. So here we go. So the first thing we're going to do is, this is the 3rd week they've come back. We've gotten to know them a little bit. They're kind of familiar with what they're going to be doing. We review the home activities. And like I said last week, this is just a time I kind of ask them about their week. I kind of see, is there anything new, anything that they're seeing, how their participation level is. Are they getting their 20 minutes in? Are they getting 20 minutes in 4 separate days? Or are they trying to pack everything into just 1 or 2 days? Trying to make sure that they're not just not doing all their activities and then, oh no, it's therapy day and they're trying to get 20-30 minutes in right before they come to see me, but really having that consistent therapy time, exploring how they feel that it went, exploring how the parents think that it went, how well did they think that they participated, did the parents really have to push them to do it? Or hopefully we're starting to see that the child is, 1, can be enjoying their activities, but 2, they're starting to begin to see, oh, as I do this, I'm getting better, or I'm seeing changes, or things that used to be very frustrating, I'm starting to see that they're not quite so frustrating. Parent participation, making sure is somebody watching them, helping them to discern, especially if you have a child that's probably under the age of 10. Sometimes their self-awareness is not quite there yet, and so they may be doing the activities, but they're not aware if they're doing them correctly or if there's modifying or adapting going on, whereas the parent being involved is going to help that child to do them more correctly, but also help the parent to get more of a better understanding of what therapy is all about. And that will help on that buy-in by the parent. Also, going back over screen time. This is something we do every week because it seems like it takes some traction. And I know that there's a lot of things that compete for our time. And so I'll tell them, we're trying to keep it to no more than an hour a day on any type of device, no more than 20 minutes a day on a small type of a device. But we say, if you guys are planning to go to a movie or you're planning to do a show, a movie at home and eat popcorn, that's not what we're talking about. What we're talking about is you have some passive time, you have some free time. Instead of using that time to be sedentary and just sitting down and watching something, we'd rather that you go outside and play and do something that gets both sides of your body working. So some of that bilateral integration, some of that gross motor activity that we've asked them to do. So We go through their activities, see how they're doing, and then we give them their rewards, whether it's tickets that we used. Some other people have point systems, whatever it is that is kind of your reward system for going over that homework activity. This is also the time that I say, okay, now you've been practicing and now we're really ready to go for today's session and to really see how well that you're prepared. Okay, so home activities, that's the practice time. When you come in and see me, that's game time. Okay, so now it's time to put on your game face. Now it's time to really settle in and we're going to see what you can accomplish today. I like trying to start out with something that is engaging. And then I also like to start out with something that gets them up and moving. I've talked about it in many webinars and many of the videos that I've done about vestibular beanbag toss or anything that really jumping on a trampoline, doing some pepper trampoline, something that really gets the entire system up and going versus they come in and they sit down and go right into an ocular motor or accommodative activity that kind of is more just sitting there and doing something. So I want to get them really involved. So we're going to review the Marsden ball. They've done this as their home activity, so we're going to review back, and as we're doing it, we're going to go back through some of the things that we've already taught. That feeling of compression of space. So as that ball is coming towards me, I notice that there is a compression or a shortening of space here on that z-axis. Well, peripherally, we are global, okay? We're in a sphere, and so we should feel a little bit of that compression as it comes in, and then as the ball goes away from us, it kind of expands. Doesn't mean that as it comes in that we're closing off periphery or closing out the magnocellular information, but we're really paying, as we converge in, we're understanding that our bubble of awareness are the things that we're trying to pay attention to are coming closer, and that reference points of all those other items that are in the room are going to feel like they're coming just a little bit closer. Then this is week 3. There should be a better understanding. How do your eyes feel when they're converged? How do your eyes feel when they're diverged? So not just I can do it, I can track the ball in, or I can look at the ball that goes out, but I feel what my eyes are doing. I feel the difference between the two. And now is it more of a smooth vergence versus I'm catching up to the ball, or the ball's gone and then I'm snapping my eyes back out and trying to find it somewhere in space. So that feeling of convergence and divergence, is it tracking through space? Going over the 3 hits, palms where they're hitting that center of that palm, fists where they're hitting that flat part of the fist with that thumb being up, keeping that radial arm nerve up, thumbs getting right there on the pad, knowing that they're not punching the ball is not kicking up, it's not lifting, it's not moving, but really not spinning, but they really sense it's just perpetual motion. I'm just keeping it moving back and forth from myself because I know where I am, I know where the ball is, and keeping that moving back and forth. Then we'll review those 3 catches, the T catches, the fists, and the bird beaks. And basically on this one, I'm looking for that coordination, that as the hands are out, that they're moving at the same speed that the ball is swinging towards them, so that the ball and the hands meet together and the ball and the hands release together. And so it's just a nice smooth, they're not anticipating, and so they get their hands down here and then catch the ball, or they're not reacting where the ball's already there and then they're snapping their hands together as fast as they can. So really nice smooth catches, control with the fist, being able to catch it and pin that ball in between. And then we do bird beaks. Instead of thumbs, we put bird beaks together and catch that ball in between. Now, I don't know if all of you have been able to listen to the previous webinars, and especially these series. In this series, we're not really teaching the activities. We've already had some webinars where we've talked about the activities and we've talked about how to do the activities. By now, we feel like everybody should know what those activities are. So now we're just talking about how do we plan them? How do we use them in office? So if we talk about an activity today that you're not aware of, or you would like more information, you can send me an email and I can direct you to how those activities are actually done. But I think we all know Marsden ball pretty well. So now we've reviewed, we know they're at that 80-20%, they're successful, and so now we want to begin to load it because our goal is mastery. Okay, so the goal is not just to be able to kind of function just a little bit better, but to master their visual system and to master these activities to where they really feel confident that I can track a ball through space, I can touch where it is in space, I can catch it, all these different things that are happening in this binocular world that they're living in. So I'm going to start with these new loads on the Marston ball. So I can look at loads in these different categories: cognitive loading, vestibular loading, accommodative loading, or binocular loading. Okay, so any of my cognitive loads, they're going to be just doing the basic activities that we've already discussed: palms, fists, thumbs, whatever it is. But we're going to add that cognitive load. So saying the letters of the alphabet, counting, words for letters, so that you're going to that next step. Sometimes I'll end it with a high cognitive load and we'll do, my name is, I am from, and I sell, and it's all the letters of the alphabet. So we start with letter A and they say, my name is Adam, I am from Anchorage, Alaska, and I sell anchovies, whatever it is, but really high level cognitive loading while they're continuing to keep that periphery open and judging where that is in space and being able to still meet their hit requirements, moving that ball back and forth. Then vestibular loads, this would be balance loads. So I usually start with the lifting of the leg. You can do this same side ipsilateral where they're just lifting the right hand and the right leg and they're touching the ball. Now, the main thing that I look for on this is you want to make sure that the knee is coming up and that the heel isn't going back. Okay, so it's not just lifting the foot off and kicking the heel behind them, but they're really lifting that knee up, because when we get to the contralateral, now we're into that crawling motion. So they're raising their right hand to hit the ball, but they're lifting the left leg. Okay, they're hitting with the left hand, they're lifting the right knee, and so that they're really starting to get that bilateral crawling pattern as they're doing this. If I've been doing a cognitive load, I will stop the cognitive load, then add the vestibular load, because I want to make sure what is it that broke down. Okay, if I leave the cognitive load and add the vestibular load on top of it and they can't do it, well, was it actually the vestibular load that caused the problem, or was it the two combined together? So I'll drop the cognitive load, add the vestibular load, see if they can do it same side, see if they can do it opposite sides. If they're able to accomplish that, so I know they can do it cognitively, now I know they can do it vestibularly, now I will add both of those together, and now they start doing the cognitive loading with the vestibular loading. Other ways to vestibular load, you can add just a pillow so that their feet are on the pillow, so it's just kind of an unbalanced place for them. You can add balance boards. Okay, then we'll use balance boards and they have to do all their hits while they're keeping that vestibular balance. So those are different ways that you can load it vestibularly. Then accommodative, or increasing the parvocellular aspect. You can have them say specific letters that are on the ball. If you notice up here, there's different letters on this ball. So as the ball is coming towards them, they have to read the letter. Okay, as the ball is going away from them, they pick a letter and see if they can watch it as far out as they can, and are they able to keep it clear and single. Okay, so that's the important part. Is it clear and is it single? Is it doubling or moving on them, or is it keeping it single? Okay, so those are basically the accommodative loads. It goes from a far look to a close look, and just the ability to know which one that they're actually fixating on and can they make that clear. I have never really added any type of flipper or any type of lens type of thing for an accommodative load on Marston ball, because I'm more interested in just that true space feel, and then that near far accommodative. I think there's better activities that I can use flippers with versus trying to incorporate it into this. And then lastly, binocular. Marston ball is a great way to load binocular. If you just have a white ball Over here, you can put red-green glasses on them and see if they can maintain luster as that ball is coming in. Does it stay luster, or does it go red or green? As it goes away from them, can they maintain luster, or does it split on them? Maybe you have two, or maybe it only goes one color as suppression or diplopia. So binocular is a great way to do it. These ones that have like the red markers on them, you can do it as an MFBF activity so that you can kind of work that. I like this one here. This is actually an emergent one, but what we do is I'll just take a white balloon, snip it, and then leave that white balloon over the top of the ball, and then I can write on it with red markers. If they're not ready for letters or numbers, I can put smiley faces, stars, shapes, whatever I want, and then that gives me a suppression check or a binocular check as I'm working on that Marson ball. So these are the ways that we're going to load the Marson ball for this week. Again, looking for that 80-20 breakdown. So whether that breaks down at the cognitive level, the vestibular level, any of these levels, wherever that breakdown is, I want to find that happy medium of frustration and success. And that's what they're going to work on for this next following week. So now, because this is the third week, this is the time that I tend to look at primitive reflexes. So I would like to know, anybody here, do you guys do primitive reflexes in your clinics? Anybody?
Yes.
Yes.
Yay, good. See, that was easy to say. All right, so we do some primitive reflexes. I will tell you right now, I do not feel qualified to really go deep into these. I'm still learning a lot on my own. I think it's fascinating, but there are some really good people out there that have their own training programs. They have videos, they have DVDs, they have booklets. So if you're doing a lot of primitive reflex or you're interested in it, I would highly recommend find some other additional resources to look at it. What we found though is that a lot of times, because development, all these things have to happen together, that if there are primitive reflex issues, because of that breakdown in that side of the development, it does lead to sequential breakdown in the development and other parts of the human existence, vision being one, spatial logic, planning, sequencing, all these different things. It trickles down through all of it. And so we are all born with primitive reflexes, okay? They are movement patterns that are designed to ensure immediate responses, okay? They're not voluntarily controlled, they're automatic, okay? We really don't think about them, but they are doing something for us in a time that we can't do it for ourselves, okay? So these primitive reflexes, they're some of the earliest examples of flexation and extension. So all the time, my wife, when she was expecting our children, would always talk about, you know, the baby's moving, the baby's somersaulting, the baby's flipping, baby's doing this and all these different things. And we were actually in college during the time that our first child was being born. And some of the other girls that were in some of the classes, they would, you know, want to feel that baby move. Well, that baby, a lot of times, is going through that flexation, going through that extension. It is that time that those wires are firing together and wiring together and making sure that everything is going to work according to the time that it needs to, okay? They're precursors to all the basic movement patterns that we're going to need, and they actually lead to the movements of the eyes, the vergence, the accommodation, the ocular motor are wrapped up in some of these primitive reflexes, okay? So if they are retained instead of integrated, okay, integrated meaning that they've reached the time that they're no longer useful, now they've been switched over to more of the cerebral part, the cognizant part, that I'm taking care of this, then all of a sudden you have two systems that are almost at war with each other, or at least causing friction between each other. that they're trying to work, okay, but yet this primitive reflex is trying to do its part at the same time. And that's when things begin to get just kind of tied up. And so we don't have therefore. So therefore, a patient's retained primitive reflexes will interfere with their progress in vision therapy. Okay, so that was a lot of words to get to that part. So we tend to want to do this testing after we've had a little bit of time with the patient. I've had time to observe. I've had time to talk with the parents. I've had time to kind of feel them out and to explain some different things to them, because now as we go into this, we're going to be explaining why are we doing this, okay? So make sure to explain to your patient and to their parents why we do these seemingly not visually related activities. Has anybody ever had the problem where you go to do primitive reflex training or testing and parents are like, why are you doing this?
Yes.
Okay. So when we begin to talk to them, we talk to them about how we're born with these reflexes and that they control how our bodies move. But we want to get to the point where we learn how to control our own bodies and not have our bodies control us, okay? And we can talk to them. You know, when you first came in, remember you talked about how, you know, he's a little bit clumsy when he's walking down the hall. He'll bump into things. Or dads, especially, that, you know, he's having problems in sports. He doesn't seem to be able to kick the soccer ball, or he can't catch a ball, you know, all these different things. And we kind of tell them about that's because their body is trying to control everything instead of them trying to control it. And relating it, I like this example. I think that Dr. Sannett uses it, that the eyes are the camera, okay, but the body is the tripod. And so we set a camera on a tripod to make it stable so that we can get a better picture, right? So the same thing, if the eyes are the camera, if the tripod, the body, is unsteady, then we're not going to get as clear as picture as if the body was stabilized and be able to hold itself in space the way that it needs to. And if we think about primitive reflexes in Skeffington's circle, all apart that anti-gravity, that ability to know where I am in space, where my body is in space, and control my body within that space. That's what we're wanting them to do, okay? Then these activities that work on control, big muscles teach little muscles. So learning how to control these big muscles will also help us to get better control over the small ocular motor muscles, the ones that control our eyes. So there are many types of reflexes. We don't test for all of them. These are just a few that we test. We look for those that have what we believe have the most direct involved with vision. There's many people that have others that they test for, and that's great. Anything that we can do to help. Now, in our clinics, if we have somebody who has a severe retained reflexes issue, we will always look to refer them out, usually to an occupational therapist or somebody specializing in reflex integration. We've even had times where we've had a child, we've said, you know what, they probably need to go work on this vestibular work and this primitive reflex integration, and then come back to see us afterwards. Because when you look at those that really go deep into primitive reflexes, sometimes they will spend 40 weeks just on the first one. Okay, usually the Moro reflex. And so they'll do 40 weeks of therapy on a single reflex, and then they'll go to the next one, and then they'll go to the next one. Well, as vision therapists, we don't have that luxury. We don't have the ability to spend, you know, weeks upon weeks upon weeks going through all these activities. So if somebody really has a deficiency, then we want to refer them out so that they can be helped by that specialist. Okay. For others in as our patients, then we just kind of incorporate some of these integration activities into our vision therapy, and so that way they're getting the benefit of both. So other than the Moro walk in our coding, how we mark everything, it's as an oculomotor bilateral integration activity. Some people put it as a general motor activity. because these tests require you to touch the patient, you always ask the parent or guardian to be present, and then to ask their and the patient's permission to touch them, and then just limit that touch to what is actually necessary. I, as a male therapist, a lot of times when it was time for me to perform primitive reflex testing, I would get one of my coworkers, a female, to be in there either with me or that she would help me and she would actually perform some of the testing just to make sure that nobody felt awkward or there's any questions. So when performing the integration activities, always remember that slow movements, okay, are critical to proper integration, okay? So remember, neuromuscular confusion, that little stutter where the muscles and the neurons just quite aren't, I don't know what you're wanting me to do. If you just skip over that, it's not going to solve itself. So slow movements where that hesitation is until I get control of that movement, that's what we're looking for. So the Moro reflex is probably the most one that we think about. The startle reflex should be integrated by 2 to 4 months. It's triggered by sudden unexpected occurrence of any kind. It may be vestibular, so head movement, especially forward or back, or something that startles them. It can be noise, it can be visual, all these different things. They're going to have that startle reflex, okay? Because it is a reflex that triggers the fight or flight response. This alerts the sympathetic nervous system and sends the patient into instantaneous arousal. And then you have the release of stress hormones, hypervention, increased heart rate, reddening of the skin, all these different things. Now, if we know that for a child to learn, they have to feel safe, if their Moro reflex is startled, then all of a sudden we know that they've gone into a sympathetic response that is now not going to let them to learn the activity that we're looking for. So this is why this needs to be addressed, because we've got to get them to the place where they can relax and trust their visual system, their vestibular system, all the systems to trust itself, that it doesn't have to keep self-protecting by going into this Moro reflex. So these things will produce hypersensitivity. So Moro, vestibular problems, ocular motor visual perception, all these different things. I'm not going to read all of them to you, but I want you to think about, if they have these, think about that keyed up child that is just up all the time. He's going to have cycles of hyperactivity where he's just go, 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 go. Well, after a while, you just can't maintain that. And so then they just crash. They just bottom out, okay? They have difficulty making decisions. They have low self-esteem. In school, they're usually overreactive. A child that is happy, 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 and then something happens and now they're just bawling. They're just crying. They're just either really high or really low. They're just bouncing all over the spectrum, okay? Very hypersensitive. They're stimulus bound. If something happens, they're going to react. They cannot self-regulate. And then they have difficulty with ball sports, because if their foot kicks in, the whole body wants to pattern after that. So if they turn their foot and try to kick a soccer ball, they usually end up kicking themselves, and that gets frustrating to them. So again, we're going to go through this quickly because it's not really the training on how to do, but the head drop, patient lies on their back. You're going to support that head, okay? And then you're just going to drop it just a few inches, and then you're going to look for how their response is, okay? Now, it's only 2 or 3 inches, and then you're going to catch it immediately, okay? Even have a pillow underneath their head just in case. But, you know, you do not want to do this if they have a TBI or a history of neck problems. Even children, sometimes you find out, oh, they were in a car wreck when they were younger. Well, these are things that you're going to want to check with your doctor before you'd perform this. Then you can test the auditory behind them so they can't see you. You clap in one side, clap at the other side, see if there's any type of response, and see if that auditory stimulation affects them. And then visually, just taking your hand and thrusting it towards them, okay? Even doing that to me kind of, you know, freaks me out sometimes. But moving your head rapidly to the patient's face, now you're looking for their responses. Is there an intake of breath? Do they move their hands or their arms and that startled, putting that out? Fear, even dislike, tension, okay, anxiety, anticipation in their stomach. They just feel their stomach tighten up. Redness, sometimes laughter, okay, laughter and crying can be, you know, really close together. And so rapid heartbeat, even if they say, you know what, I just felt off, that made me feel queasy, I just didn't like that, then we would probably put that as a positive response and then start working towards integration. So things that we're going to do is neck mobility. And if you remember this one, they're going to start with their head down, and then they're slowly going to move their head in a clockwise or counterclockwise pattern, and they're going to go all the way around. But again, remember, it's very, very slow. It's not just sitting there and moving their neck around, but it's very, very slow. And anytime they feel that little hitch, okay, that little place where oh, I didn't quite control that, then they're going to stop and go back and just kind of massage that area, and then slowly keep going around. The starfish, where they cradle in right over right, left, and then they're going to go all the way out, and then they're going to cradle back in the opposite, left over left. And so they're going to make that starfish out and then bring that back in. Prayer pose. Prayer pose is very powerful. You need to be careful with this one. This one literally takes them and they have to arch their back up while they press their hands in. They're lying on their back, they're holding their breath as much as they can, and then they're exploding out with their breath and their limbs as far as they can, as fast as they can. This one is a very, it really lets go a lot of emotion. And so if you have somebody that has experienced trauma in their life, you may be careful. I've had people that when we would do the prayer pose, we'd have to have a box of Kleenex, because it would really cause a release in them of releasing a lot of tension, a lot of anxiety, a lot of baggage that they've had over the years of their life. And so it's a very powerful one, but you want to be a little bit careful with it. And then we're all familiar with the duck walk, okay? So the pigeon, you know, pigeon toes in, but he's carrying a pizza. Our duck, the toes are out and he's riding on a motorcycle. So that's what we put as the Moro walk. And then another good one is called the vagus nerve activities. This one is if you have somebody who's really, really sensitive and some of the vestibular loads and all these different things would be difficult for them. This is one that they can do at home, just laying down. They can even take their hands and put them behind their head like they're laying out in the lawn looking up at clouds. But basically they're going to take their eyes and shift them all the way to the right, hold that for a minimum of 30 seconds, preferably up to 90 seconds. And then they're going to slowly bring that over and go all the way to the left. Again, hold it for 30, at least 30 up to 90 seconds. And then they're going to bring that back to the center. And then they're going to do it with their eyes closed. Okay, so now eyes closed all the way to the right, back over to the left, back to the center, and then eyes open. And usually what I have them do is about 3 rounds, eyes open, eyes closed. Less of that causes symptoms of that, you know, is too much for them. But what you'll find is as they do that, they'll begin to kind of sigh, or maybe they'll have a little catch in their breath, or maybe they'll just take a deep breath. That's what you're looking for. You've hit that vagus nerve reset, and it's starting to allow them to go from that intense sympathetic state to become more relaxed and come out of that. Okay. So then you have the TLR. So the tonic labyrinthian reflex. This is as the head moves forward or the head moves back. It's connected to that labyrinthian system, okay? So that gyroscope inside our brain that's telling us when we're at level, okay? But these tonic, or the tone of these muscles, affect that. And so if we're really tight and stiff in here, it's going to affect it. Or if we have zero muscle tone in here and our head's just kind of floppy, that's going to affect it, because it's probably going to mean that our head's going to go forward. Now we're kind of off balance. These kids are going to walk up on their toes. you know, because they're stumbling more than they are walking. When we look at this, a lot of times that we're looking at is stiff, jerky movements, ocular motor dysfunction, visual perception. They also have a lot of spatial problem. They know where they are in space. In school, the reestablishing binocularity when looking near to far, auditory processing problems, organizational problems. So these are all things that are very school related. So laying them on their stomach, shoes off, their feet, everything is down on the ground, arms above should be at a 45-degree angle, but the palms should be down to the ground. And then you want them to lift their hands, their head, and their feet all at one time simultaneously. So you're looking, does the head go, then the arms, and then the feet, or which one, or certain side? Sometimes you'll see all the right side go, and then the left side will join it. You want to see if it all comes up together, okay? Now, if they're doing it standing, if you put them standing, you're going to have them tip their head down. Your eyes are going to be closed. You want to make sure that you're standing behind them to catch them, either forward or backwards. And then they're going to put their head forward, and then they're going to bring their head and put it backward in about 10 seconds each time, okay? And they're going to repeat this 6 times, okay? Responses, loss of balance, boom, you know it's right there, okay? Balance change, sliding from one side to the next side, okay? So they're trying to compensate for that loss of balance. Dizziness or nausea, okay? If they're like, oh, this is throwing me, then you want to stop, and this is probably you just mark this as positive, okay? Again, we're going to do neck mobility. Then earth hugger, they're just going to lay on their stomach and push themselves into the ground, okay? Superman, it's the same as the test. They're going to lift their feet, they're going to lift their hands, they're going to lift their head, just like they're trying to fly like Superman. ATNR, okay? So the archer reflex, as this hand goes up, does the hand go with it? Okay, how does that move together? So we're really looking at the crawling, okay, with fluent cross pattern, okay, leads to crossing the midline. All this should be done about 6 months when they really start crawling and start moving, okay? So this is a hand-eye coordination. So when we look at this, handwriting, expressing ideas in writing, poor eye tracking, those are the kind of the school reasons. So if we're talking to a parent, this is what we're trying to help them with, because they're probably really going to have poor ocular motors and very poor pursuits, especially as it crosses that midline. They're usually very one side dominant. Okay, patient in tabletop, that means they're on the hands and knees. Make sure the elbows aren't locked. You're going to pull the patient towards where most of the weight is on their arm, and then just kind of rotate their head slowly from one side to the other, and you'll see a positive if they begin to drop their shoulder in either way. And so the activities that you're going to work on are eat the apple and stair climber, okay? And again, if you need directions on any of these, I'm happy to provide them at a later date. STNR, okay? Head towards the chest, cause the arms to bend and the legs to straighten, okay? All these different things, they're important. These should be done about 11 months, okay? But these kids are going to have poor posture. They're the ones that kind of slump or kind of hold themselves up. When they walk more with one side of the body and then the other side of the body. They don't have good bilateral. They have poor near-far vision. Going back and forth between a chalkboard and their desk is going to be really difficult for them. So again, tabletop, okay? Arms, elbows, make sure they're not locked, okay? Make sure that there's some give in them. Then you're going to pull them again towards, and then you're going to, instead of turning the head this way or this way, you're going to raise the head or lower the head to their chest. And you're looking for that shift in weight where they're either going to slide back to their haunches, or they're going to come back, or you're going to look for that back to arch up like a cat, or them to go really, really swayed back. And so you're just looking at that. So then the integration, we're going to use that neck stretch and then that cat stretch. So just like the yoga poses, cat stretch is a great one to help them with that. Spinal column. This one here, if you see it, it's there. Like you know when you see it. But what basically in that tabletop position, we're going to be testing them, and you're going to be hitting it. We're going to talk about that spot just above the hip bone and just using the end of a pencil, okay, and just kind of poking that. But if you have a child, especially boys that are 9, 10, 11, 12 years of age, and they're probably still wetting the bed, this is probably what's going on, because the spinal gland is when the hip moves, then it releases the bladder. Okay. Other things that it does is its poor ability to sit still. They always seem to be fidgeting, and then they have very poor concentration. Okay. As they're up, again, elbows not locked, feet straight, toes flat. Here's where you're going to ask permission. You're going to raise the shirt just about 3 inches off the back, and you're going to touch the skin at the lower back. It's just a quick stroke down in about a 1/2 inch, and then towards on either side of the spine, opposite side of the spine. You don't want to, it's not like you're trying to punch a hole or anything. It's just like an acupressure point. You're just trying to hit it. The responses are going to be hip movement, arched back, or hypersensitivity, or very ticklish. Okay. Integration for this is controlled angels in the snow. Okay, so making sure that they really coordinate those movements. Okay, and then that there's really proprioceptive body awareness, where my body is moving in space, what leg is moving, what arm is moving, and that they're really controlling that aspect. Palmer one, real quick, we know that one, that's the gripping one. Okay, so if they are still having that, then you know that you're going to have to do a lot of fine motor skills. So you can do like penny push-ups, you can do string pulls, you can do the paper tears. Anything that is fine dexterity will help with that Palmer reflex. Okay. So here's a list. I'll just let you look at it. Again, this will be up on our YouTube channel next week, and you can get it and really write it out. But these are the different primitive reflexes, and then the purpose of the reflex, when it appears and when it should be integrated by, and then signs that they're still holding on to that. Okay. So that is going to take the bulk of your 3rd week. Okay, it's going to take a little while to go through the testing, and then to go through with the parent why, how, all these different things. I'm not going to send any activities home for anything that I found in this 1st week. All I'm doing is making the notes, making the testing. Then the following week, I will start to give them activities that they can do. But I want to be able to teach them that activity, make sure that they're going to do it correctly before I send it home. So if I do have extra time, I'm going to go ahead and review the Hart chart. I'm going to review where I left them. And then we're going to start adding our loading. Again, cognitive loading, vestibular loading, speed. So how fast the metronome goes. Now, speed loading is twofold. One, I can load it going up, but I can also load it coming back down. So let's say I get them up to 90 beats per minute. Well, then maybe I'll drop it back down to 60 and see, can they make the adjustment from going fast to going slow? And then you can always change the direction of the Hart chart from outside in, inside out, columns, all the different ways that you're going to want to do that. So Hart chart, we're going to review, and then we're going to start loading it. And then that way they'll have what they're going to do. And then if I do have time, this is the week that I start with Parquetry Blocks, or usually I plan to start with Parquetry Blocks. And the first time I do this, it's very simple. All I'm doing is direct matching on template. In other words, I take the template, I put it there on the table, and all they're doing is taking the block and direct matching to the color pattern, to the shape pattern. Okay. Now I do take all the blocks and I separate them into 2 separate piles, so that the right hand reaches over to the left side of the body and grabs from that, places that block. Left side grabs from the right side and puts it that block. Okay, so that they're always crossing the midline, and they're always taking a block from opposite sides as they're going. Okay, that can be as much of a load as a child can handle at times. Okay, if I do want to load this one, I can load by non-repetitive shapes or colors. So if they pick up a diamond, then the next shape they pick up can't be a diamond. If they pick up a blue, the next one they pick up can't be a blue, even if it's a blue triangle. So you can say non-repetitive, or you could, whoops, or you could make it into groups. So they have to put all the squares on first. Then they have to put all the triangles on. Then they have to put all the blue diamonds. They have to put all, you know, you can make it whatever groups that you want. Okay. Then you can do all of a certain color. So everything of certain color has to go on first, and then you can move on to the next. And then the last one is we would do delineated. If they're doing a delineated, one thing that I look at, okay, so here's all this. You see how each one is lined out. So that is a delineated pattern. So when they put that block on, I'll say, now, are you parked in the parking spot? Or are you kind of hanging over? Like if mom parked at Walmart like that, would her car get hit? So that they know that it has to stay within that shape, okay? After we've done delineated, if they're really quick at that and that's not a problem, then even in the first week, maybe I'll go to direct matching, but I'll go over here to the non-delineated. So now they have to use multiple blocks to create these shapes. So instead of everything lined out for them, they have to be able to visualize how different blocks together would make the shape that is required. So that would be the parquetry blocks. We keep parquetry blocks within our home kits. And so when I go to my home activities, we're going to continue with general home activities. They can do word searches, dot to dots, hidden pictures, sorting activities, card activities, all those different things that we've allowed them to do. We're just going to encourage them to keep doing that. And now, if I know I said that, if maybe they only had one reflex like the Moro, okay, I may go ahead and teach them how to do one of these activities. So either the duck walk or the pigeon walk, or maybe the starfish or the neck mobility. And then I may send something like that home with them, but very, very simple. Okay. Then parquetry, they would take and just do their pattern matching, Hart chart, and then of course, gross motor play, keeping with the list that I've given them, and then anything that they can find off. But just like these kids over here, the more that I can get them out at this stage, running, jumping, moving, all that is going to help in all that development. Okay. Special thanks again. I want to thank the Emergent team. I appreciate their support in putting these on. And then iHeart VT for them putting us up onto their site, and Vivid Vision, those two groups together, working together, just trying to get more and more content out there for us as vision therapists. I really appreciate all the people in this community that help us to gain knowledge so that we can better serve our customers, our clients, however you however you talk about them, whether they're patients, but the people that we're trying to help. I appreciate these ones that are helping us. Any questions today?
Thank you for a lovely presentation, James, and it was nice to meet you.
Well, I appreciate that. Again, I will try to have this up on the website next week. So if you want to review it or go back, or if you want to point anybody to it, that'd be great.
Terrific. Thank you.
Anyone else? All right. Well, thank you so much, everybody. I appreciate it. And I hope that you all have a wonderful day.